if you really want to learn the nitty gritty of pathophysiology and why this process is going on and why, the stuff you're already doing, but you want to learn it to the infinite degree, then I think, yeah, you should go forwards. However, there is the give and take, and you lose that touch with your patient that you have at bedside. It's gone. If money is the motivation or not wanting to be around patients as much or something like that, I don't think you're going to find the satisfaction that you're looking for. So that would be what I would ask them is why? What is the motivation?
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks for downloading this episode, and thanks as always for listening to the podcast. Don't forget to share this podcast with your friends, people you like, people you don't like. Everybody, every ER nurse needs to hear this podcast. Now, today's episode is a part 2 of my last episode with the fellows from Just Some Podcast. If you haven't heard that episode, you may want to go back and take a listen to that first. I mean, you don't have to, but you're going to be a little bit confused if you don't. So go on back and make sure you've taken a listen to that one. If you have, then go ahead, hit the play button, and we're going to continue that great podcast. I think you're going to really dig it. So enjoy this podcast with my friends Ben and Tom from Just Some Podcast for Advanced Practitioners. Enjoy. Tell me about a patient. I'm going to ask each of you this question. Ben, we'll start with you this time. Tell me about a patient that touched your heart.
Well, I actually have two for probably different reasons.
Okay.
And of course, we'll go back to my ER days because that's what the show's about. I had this 14-year-old girl come in, and we actually had to go out to the car and get her out of the vehicle and get her back. Stats are like in the 70s, I think. Initially asthmatic, had been trying to do, stuff all day and just wasn't able to bring herself out of it. And we are able to turn things around for her. I remember that she was so far down as far as, where it was almost to the point we wouldn't have been able to bring her back, that she'd lost control like bowel and bladder. And so we were able to, turn things around. Her grandma actually worked at the hospital. And so after we got her stabilized and we were getting ready to be admitted, her grandma comes in and she looks at me because I had known her and know her quite well. And she said, "We almost lost her, didn't we?" And I said, "Well, it doesn't matter now. We've got her stabilized." And she just kind of looked at me and she says, "But we did, didn't we?" And I said, and I just kind of patted her and I said, "It's good now. We're okay." So that one just kind of really resonated with me because I'm asthmatic. And so I just had, I felt that. And I think actually she just graduated from nursing school not too long ago too. So
that was pretty cool. That's pretty cool.
The second one was a guy that had come in and wasn't even my patient. The PA that was working our urgent care had come up to talk to the doc about him. And I was like, that story sounds really familiar, because it was like his kid, him and his kid were wrestling around. His kid had jumped off the bed and landed on his ribs, and his ribs were hurting, and that's what he was in for. And I was like, that story sounds really just familiar. So I go back and look through old patients, and 2 weeks prior, someone had been in for the exact same story. Different name. And I was like, something's not right. So, me and the PA and the doc kind of talked, and we're like, let's have registration go in and ask him his social security number, because he'd given it at the desk. So we wanted to see if he would give the same social now. And so registration went back and he gave a completely different number because he couldn't remember it. And so I can remember standing there in the doorway because he's like, "I just want to leave." And I'm like, "No, you're not leaving. Like, we've already called the police because, you're breaking the law, trying to get medications and, using fake names and whatever, He's like, "No," I just need to run out to my truck. "I'm not letting you leave this room. Like, you're well, you're hold me against my will. That's fine. You can talk to the police officer about that when they get here because you're not leaving. And police get there, arresting, taking. Don't think too much more about it other than that was kind of a weird day, It's probably a year later, working, phone rings, ER this been. And he says, hey, my name's da-da-da-da. And says, I don't know if you remember me. And of course, the name at that time registered with me. And I was like, no, it doesn't really ring a bell, even though it did. And he says, I was when you had arrested. Oh, okay, yeah, okay.
That's awkward.
Jogs memory a little bit, yeah. And he says, I just wanted to thank you. And I said, okay. And he said, that was the wake-up call that I needed. Getting arrested because of that and because of trying to get drugs and stuff. He said, I got clean because of that.
Wow.
I just want to call you and thank you. And I was just like, wow. Like, that is just crazy to think that was his wake-up call to get clean. So that would be probably the two patients that really just impacted me and stuck with me.
That is not the way I thought that story was going to go. Like
that wasn't how I thought the conversation was going to go either. Let me assure you.
Yeah, you're like, oh, okay, yeah. Well, that's kind of cool. That's you never know what kind of impact you're going to have on a patient, and I'm always surprised at how well patients remember folks. And now, the people on the podcast aren't going to be able to see us, but none of us are small gentlemen. So, and sometimes, that alone makes you easy to remember. But it's, when patients remember you for stuff and you're like going, that's kind of cool.
Yeah.
That means we're doing some stuff. So.
I don't know. Because I have several, and when I think of the word touched my heart, I think of something good. And I've had lots of great experiences, seen some stuff, done some stuff, especially, oh my God, a child, that we had to end up intubating and stuff like that. That was just heartbreaking. And I'm trying to talk to the parents who are literally standing next to me while I'm holding the ET tube because she was so small we couldn't tame her. There was no tube tamer. And so we're like, so this is what I'm doing. This is why we're doing it. That's one that stands out. But honestly, and the one thing that stood out the most in my head, and it's actually not a good thing. It's not a fun story. It was for people they think about ER nursing, or they think it's like some people, I guess, think it's glamorous. I don't know. ER supervisor, extremely busy day. And when I say extremely busy, we were not a large ER. We were okay. We, saw several hundred people a day, but nothing outrageous. At one point, and this is not a joke, in a several hour period, we had three stroke alerts, 2 STEMIs, and not one, not two, but our second alternate landing site for our incoming helicopter was being set up by police out in a field. And this lady was throwing a fit because they had discharge paperwork and they had not been discharged yet.
You're like,
and I was like, I'm trying to help facilitate stuff. Like so I grab all the stuff I can and I'm running in there and I'm like, hey, I'm sorry about your wait. And the daughter is with the mom. And the daughter at first is just riling the mom up. See, mom, they can come in here when you bitch enough, and just starts going off. And I'm like, oh, this is going to be great. And the mom goes off. How stupid I was. I was a worthless, stupid animal. I will never forget that. That's exactly the words. You are a worthless, stupid animal. While, mind you, it was like noise to my ears. I could hear the helicopter coming in on top of the building. And she is just going off about how worthless a human being I was. And then I saw the daughter try and stop her. Like, whoa, wait a second, mom. And I actually pointed at her. I said, no, you wanted to hear it. I did. I said that to her right to her face. I was like, wanted to hear it. You wanted this. Yeah, you wanted this. And I just, no, go on, ma'am. And I think, honestly, by the end of it, the daughter was sad Like, I didn't realize like this is what was gonna, and I was like, look, I'm not going to discuss other patients' care with you, but the reason you couldn't be in here is because we have so many people that are going to die if the doctor's not in the room with them that we couldn't print discharge paperwork for your knee pain,
you're like,
or toe pain, or whatever it was that day. And so it touched my heart because I saw both the ugliness of what people could do, and then I saw. And I'm going to try and keep it. I'm not known for being positive, but that look on the daughter's face, like, oh, like I could see her
like,
wilt.
I went too far.
Yes. And I was like, for maybe just a second, the next time somebody says something, she'll be like, hey, they were having a rough day, like give them. But I don't know so much that it touched my heart, but that's one of the few things that is burnt into my memory. I try and forget the traumas. I try and forget. You can't forget them, but I don't want to remember.
It's a lot you don't want. There's a lot you don't want to remember.
Yeah.
Put it in a box. Shove in the back.
Yeah. You
close it up.
Trap that
close
for
it
later
up
on.
nicely and tuck it away so you don't have to think about it, because otherwise, you may need therapy by the end of the week, right? Like.
Oh yeah. No, you have to compartmentalize. I mean,
we do that to some degree. So that's for sure. So one of the questions I want to ask both of you is, I have two nurse practitioners here, two former ER nurses that have done some other stuff too, but you guys are both nurse practitioners now. And one of the things that I get asked all the time is I always get asked, hey, do you think I should go to nurse practitioner school? And my answer is always no. No, I'm kidding. My answer is always, I was like, I can't answer for you. The answer for me was not in the cards for me. But what advice would you give an ER nurse who wants to maybe become a nurse practitioner? What are your thoughts on the current role and how to get there and what do you got to do to get there?
My advice would be very simple, and it's going to sound very crass, but I think once I explain it, it'll sound better.
Okay.
If you truly want to go to be a nurse practitioner and you're an ER nurse or whatever you are doing currently, leave bedside. I say that because you've got to be able to make that transition from nurse to provider. To make that transition from I'm getting orders, even though you have input. I'm not saying, ER nurses don't by any means. I mean, it's very much a team effort, but you're still ultimately receiving orders to being the one giving orders. And that is a transition that has to take place in your mind. So what I did whenever I decided I wanted to become a nurse practitioner, once I got to the part of doing clinicals, I left ER. I, heart and soul left it. I went to IT and worked as a clinical informaticist, as working on the system that we use in our clinics. Because I had to have that break to be able to make the transition in my brain. And so, that would be honestly the one piece of advice that I would give.
I think that's one of the things that I've seen people have a hard time making that transition from, being the one taking the orders to the one giving the orders. And a lot of times it can't happen in the same, it's hard to happen in sometimes the same environment, right? Like, if you're, and very few people I know have done that. And even fewer have done it well, where you make that transition from being a nurse to a provider in the same organization, same department, same whatever. Because you never get a chance. And I did it as going from a tech to a nurse, and that's not near as a big transition from nurse to NP. But I remember one of the ER docs going, "Oh, you're not a tech?" And I'd been a nurse for years. And I'm like going, "I'm wearing the nursing scrub colors." And he's like, "Oh, we have scrub colors for nurses?"
It says RN on my badge.
It says RN on my badge. And you're like, "Hey, well, you're the tech, right?" And I'm like, "No, I haven't been tech for about 5 years." So it's hard to make that transition sometimes. And especially in your own department, don't think, I have a friend who went to nurse practitioner school, and she did, NP and did FNP and then did the emergency NP. And she, they were like, "No, we're not going to transition you into the role here." And she ended up going and doing something else.
And, and that was, I had a lot of people like, hey, are you going to come back? And honestly, that was one of the things that worried me, was transitioning to a provider in the same ER you were a nurse at. It can be rough. Yeah, it can be rough. To anyone that's in the ER that wants to go forwards, I don't know. Why? Why do you want to go? If it's because you want to be the best, and I don't mean like nurse practitioners are so much per se better. What I mean is, if you really want to learn the nitty gritty of pathophysiology and why this process is going on and why, the stuff you're already doing, but you want to learn it to the infinite degree, then I think, yeah, you should go forwards. However, there is the give and take, and you lose that touch with your patient that you have at bedside. It's gone. Because I will tell you right now, myself, Ben, other nurse practitioners I work with that used to be ER nurses as well, we all say the same thing. Like, there's at least one day a week we all look at each other, we're like, what I wouldn't give right now to put an IV in, what I wouldn't give to be in the ER at bedside. Yeah. So there's this misconception that moneyness, good Lord, listen to me, that money and schedule, all stuff are going to make up and make you suddenly very happy. There are very great things about working in an office, but there's really great things about working with patients in an ER. And if you are one of those individuals, I'm not going to tell you not to do it, but why do you want to do it? If you just think you're going to make more money and all this other stuff, I don't think you're going to end up any happier. I think you're going to do that. And then you're going to be like, oh, well, I need to become a realtor. Like if money is the motivation, or not wanting to be around patients as much or something like that, I don't think you're going to find the satisfaction that you're looking for. So that would be what I would ask them, is why? What is the motivation? Kind of generic, but I mean, I just think if you have and again, I'm not trying to be like all holier than anybody else. I mean, the money is a little, better in some places it's not. Yeah. But I don't think you're going to find that satisfaction if that's the cause. So
if that's your motivation. All right. That's a great answer.
That's all I got, Kevin, are great answers.
Great.
So, that's all I do. That's all I know is great answers.
So here's a question. Here's a nurse practitioner question for you. Why do they want you to have a year of critical care, and why is the ER not considered critical care?
I also think that depends on which certification you're going in and which school you're at. Because I have seen schools, especially for family nurse, they didn't care. Okay. Now, if you were doing acute care,
if you're doing acute care, like acute care, like almost exclusively wants you to get a year of ICU.
And I think I can take the ball on this one because I did ICU and all that other stuff as well. So here's what I will say. First of all, I think it should. I think ER, you could at least make the argument. Let me rephrase that. Not everybody's built the same. Okay. I think the difference is when you're in ICU, it's not controlled chaos. It's not treat and street. It is a person that you are going to intimately be involved with every detail of their care for 12 hours. Everything they do, you're literally going to monitor every drop of urine that comes out of that Foley. You're going to be in that nitty gritty. And when you are looking at some of those critical care fellowships, that's what they want. They want people that are not just used to, but well versed in the nitty gritty and details. Like, did you really look at the calcium? Did you do this? Did you do that? How many mils of urine were they making? Which, again, those are things, if we have time and that's a luxury in the ER, sure, I'll tell you. But 9 times out of 10, they weren't breathing when they got here. They're breathing now. I put tubes in holes.
There's your report.
Yeah, there you go. Report. They said they were going to die, and I said, you're not going to die, and they're not dead. So fix them. And honestly, there's a rhyme and reason to that. And I defend that as well. So I think that's the difference, is there's this expectation in the ER that it's like, hey, it's turn and burn. If I can get you in and out in 7 minutes, then that's what you're going to do. Yeah, exactly. But ICU is, I always did it instead of chaos. I always compared it to music. I was like, An ER is a punk rock concert in the early 80s. It is screaming and it's fun and people are running into each other, but they don't know why. There's a chicken for some reason. Like there's all sorts of things going on in ER, but that's just that environment. In the ICU, it is very much a symphony. It's conducted. You know the movements. You understand where it starts and you understand where it should be going. And any deviation from that path is not acceptable. Like you have got to get back onto those railroad tracks. And I think that's the big difference. That's just like for CRNA. I think they want people that they understand, breathing and apparatus and staring at a vent and doing all stuff. Cause I've been in that position. So I think that's the main reason.
Why does everyone want to be a CRNA? Like, is it
Money.
that lucrative? Is it that much more lucrative than the nurse practitioner?
Yes.
You're like, yes.
Look,
Like, yes.
look, I'm not saying
that we made the wrong choice.
And let me be, because that was my original thought when I was in ICU. Before I came back to ER, I was like, hey, I'm just going to stay in ICU. I'm going to get my CCRN.
Wants to be a CRNA. Yeah.
Well, I also think, first of all, they earn their money. All right, I don't want any CRNAs listening to this to be, other than the fact you guys wear, surgical scrubs and you just sleep. I watch Grey's Anatomy, so I know what those anesthesiologists are doing. But anyways, I'm kidding. But that, like, they make a lot of money and they have a very limited scope. Like when they're not the OR, in most states, they don't have prescriptive authority. So literally they are getting paid a ton of money for a very specialized skill that's necessary. So I don't want to take away from it, but it's a very limited. So why not? Like, I'm going to make 3 times as much as a family nurse practitioner and I don't have to treat diabetes or gout. Yeah. Okay. Like it doesn't sound like that bad of a gig, when you put it that way.
Limited specialty is taking people to the brink of death every single day and then bringing them back.
That's the problem. Yeah. Like this is controlled dying. That's what they're doing, so yeah.
We're just going to keep you alive with machines for just a little while.
Just a little alive. Yeah.
Wow. That's an interesting perspective. All right, guys. Last question. 3 things. How do you want to do this? You want to split it up? Split up the 3 things? You want to give 3 things each?
I think we're going to have very different answers. So it depends on
remembering are going to be similar, I think.
Okay. That may be true.
So 3 things. We're going to split this up. We're going to start with Tom because we're going reverse alphabetical order.
Makes sense.
Yes, great. Yeah.
And you're going to start with 3 things that a new ER nurse should always remember.
So, and honestly, the first one is something that we talked about when you were on our show, and that is control. I always use the word dominator space because that's what I coined. I don't want to say coined. I'm sure other people have said it, but that's the phrase I used when I was teaching rookie police officers. And I just transitioned it when I was teaching new ER nurses. And when I say dominator space, I don't mean, handcuff somebody, though. Hey, that could be a useful skill some days. But what it means is put out your arms. If it is not in that space in the middle of emergency, do not worry about it. Okay. You have got to control the things that are within your control. And so that may not physically be a 6-foot circle, but the point remains the same. Whatever you can control, you focus on. If you can't control it, then you better eject that shit from your brain ASAP because you've got to focus on what is at your fingertips now. And so that's always the first thing. I mean, rule 1, day 1 in the ER was not your emergency. Stop freaking out because everybody, especially pediatric emergencies, but most emergencies, especially trauma related injuries, boy, everybody wants to lose their mind. And I'm like, stop. You don't.
Calm down.
Yeah, you calm down. Or,
check your pulse.
Check your pulse first, then theirs. Or, I remember telling a newer nurse one day, we're in the code, and she is just, I'm like, look, you got to chill out. I was like, he's not going to get more dead. Okay. So you can't screw that part up. I know you're like, oh God, he's dead. Yeah, he's dead. We're trying to make him alive. Okay. You not focusing on this is impeding that progress. And granted, this was more of a conversation at the end of the day, but it was more of a, hey, let's focus on this. And that's based, that's very realistically, very real. That's what I told her was when you're in that room, you worry about that room. Don't worry. Everything else we'll deal with the other stuff. Okay. But you've got to worry about what's in your circle. So that's the first thing I tell people not to forget.
I had the same number.
Nice. I like that.
So that, yeah, I would, that was mine too. So,
all right. Let's go with the next one. What's the next thing to remember?
So this is one I had to learn myself again over time, and it's not your family's fault if you have a bad day. I don't know how many times I am an emotional person. And I think that's why earlier I got a little stuck up on your question about who touched your heart. Cause I'm like, dude, I'm emotional. I don't look emotional. I got a beard,
like all of them.
Yeah. I'm like a beard and tattoos. I've been accused of being a biker, not a nurse before at the ER. That's super fun.
Kind of got that look. That's all right.
I do have a very, 1%er look to me. I get it. That's okay. I don't even own a motorcycle. That's the crazy part. I'm like, wow.
Yeah. Oh, okay. First, let's talk about that. You got to get one.
I do need to get one, but I don't currently.
I have a Harley. And I love it.
Oh no, I love it. I definitely want a Harley. If you could convince my wife to buy one, then we'll do that.
No, forget it. Yeah, you're not getting a Harley. But you're not getting a Harley.
No, she probably would let me actually, but that's a lot. But the thing is when you're having a bad day, you have a tendency to come home. And since I had a bad day, everyone around me is going to have a bad day.
Yeah, shit just comes out.
It does. And honestly, you should vent. But there's a difference though between venting and getting it off your chest. Like, well, and then the doctor said this, and that's okay. My wife's a respiratory therapist. I let her vent all the time. But good point. But I have a tendency to, like, it puts me in a bad mood. So then I am just chief dark cloud, man. I am just, you do not want to be, I'm serious. You can ask Ben, like, there's a blast radius. You don't want to be in it. And unfortunately, I have a kid and a wife. And sometimes it took me a while to get to the whole stop being a jerk. You had a bad day and it's not their fault and you need to get over it. And the reason I say not to, I think most people instinctually remember that. The problem is when you forget it. And that's why I tell people that's a rule to remember, is you need to constantly remind yourself it's not someone else's fault. Like, it was a bad day, leave it at the office, try and move on with your life. So it's done. Like, you're home now. Yep. Sometimes it's hard to shut off though, and our brains don't know the difference between when we're at work. And that's why I say is you need, and everyone's got their own thing. I always had like a small commute. I worked at one hospital, was a longer commute. One, it was only like 10 minutes. But it was good. I knew when I got in my car and I sat down, it just kind of like my brain just started going through the process of clicking off. Like, okay, like you're leaving the hospital. Leave your trouble behind. And it took me a couple of years to really figure that out. But my wife is a saint and my kid is amazing. And so they put up with me being a jerk sometimes. But that's a definite rule to remember.
Good for you. Good for you and good for them. Yes. So good deal. I like that answer. And the last of the three things to remember.
Of the three, but then I do have a bonus one. The last one is going to sound kind of confusing, I think, at first. It's to be safe. Be safe for you. I'm a big advocate for workplace safety. I do not believe that just because you are a nurse that getting punched in the face is part of your job. I do not believe it. I did not allow it, both for myself or when I was a ER supervisor for my staff. Like, no. That doesn't mean we did 12 arrests a day. I don't mean that either. But this whole malarkey of it's part of being a nurse, I did not accept. I never have. And so being safe for you is also paramount. And feeling comfortable to stand up for yourself.
Right?
And that doesn't mean yes. And again, look, you do need your breaks and stuff like that. I'm not saying, but I don't mean that specific, like a minutia. I mean the general. You have got to look out for your own safety and well-being. On the flip side, the other thing to remember, I would tell people, is your mistakes. Because nothing will teach you better. Success makes you feel good, but it doesn't teach you nothing. But you give 0.1 mg per kg of etomidate instead of 0.3. Look at Ben. That was
everything.
15 years ago. He still remembers it. Yeah. I mean, I'm just saying, you make a mistake, and I don't mean dwell. I don't mean think about how bad you felt. I mean, pass that knowledge on. Hey, look, I know you think you know what's about to happen, but I made this mistake, and pass that knowledge down to those new nurses. Like, hey, some of them got to learn the hard way, unfortunately, but there are a lot that will go, oh, if I see this is the next likely thing to happen. And so I think that's always an important thing. But the last thing, and I want to say this, is, and it kind of goes along with the be safe, is do not be afraid to stand up for yourself and stand your ground. And that's really what I was going to say. As a provider now, and as I've been a nurse and a provider, and that does not mean if you do not agree with the provider that you should go and have an argument with them. That's not what I'm saying. But if you have a legitimate fear, question, concern, or something like that, any competent provider will stop and go, this is why. All right. And so as a nurse, you should feel on par. You are part of the healthcare team just as much as any physician, as much as any PA or NP. All right. In some ways, I would say more so. I feel far too often we get these newer or younger nurses, and it is, let's be honest, it's predominantly a female dominated workforce in nursing. And I think sometimes they feel like they're intimidated. And that's why I'm saying to you, if you are listening to this, that doesn't mean be argumentative, but if you have a question or concern, that is not only the reasonable thing to do, it's the right thing to do.
So
it's the right thing.
So if you're 80-pound Becky, who has to turn around and say, okay, Tom, who's got way more experience than I've ever do, how do you have that conversation? How do you have that conversation with a provider, an experienced provider, and say, hey, you know what, dude, I think you might be wrong. I think you might be missing something.
But honestly, that's it. I again, in the ER, I was clarity. And clarity and simplicity, especially when you're talking about verbal communication between two human beings, is synonymous. Okay. So if I can say something to you in 3 words, then that's what you need to use. Okay. Now, I might need some more information, so get the other words prepared. But if you're concerned about the amount of a medication, the route, whatever it may be, then you need to say, hey, whoa, are you sure? You told me 0.1 mg per kg of etomidate. Are you sure that you don't want 0.3 or something like that? Or, hey, and if they say, and if they're a jerk and they say something, then do it. But then feel free to go and say, look, my job, you want me to push this medicine, you better have a reason for me. And honestly, if 80-pound Becky came up to me and I didn't have an answer, then she's right. Then something's wrong.
Yeah.
So if the provider isn't giving, and again, there's a difference between him going, look, that's the standard. This is what I want. Do it. That's one thing. Okay. But if they're like, I don't know, I've had a couple of questionable responses from people well, that's what we always do. I'm like, you haven't been in to see the patient, have you? Something will click in your head. But that's the last thing I would tell them is you are a significant and linchpin member of this healthcare team, just as much as any provider, x-ray tech, respiratory therapist, whatever. And you have to find that ability. And if you want to have a conversation, a great way to say that is hey, I'm not sure about this. Can you tell me, if you want to phrase it that way, I think that's a good way to lead into it because it's disarming. It's not hey, you're wrong. It's, hey, I don't know. Explain it to me. And I think if you want to have a nice casual conversation, that's the way I would probably phrase it. But honestly, in the ER, especially depending on what's going on, if it's, whoa, you said etomidate and you said 0.1 mg per kg, are you sure that's where we want to go? And they said, hey, I went to medical school in Tanzania, which has got the finest medical schools possibly in the whole world.
Shout out to Tanzania.
Yeah, shout out to Tanzania.
We know you're listening.
We're shooting for number 1, baby. But that's what I would say. And honestly, I know this is something that people hear over and over and over, but they still are not doing it. And I think until nurses hear it and really grip it, really understand that they are on par, that they are professionals and they should feel free to be treated that way, we're still going to have some issues, but that's the last thing I would say. That's the bonus info right there.
Gotcha.
The only one that I would add to that is mental health is health, including your own.
Oh, that's something we're really good telling other people how to run their health.
Yeah.
We're not really good at doing it ourselves.
Oh, buddy. Oh, yeah. Don't smoke as we're smoking a cigarette outside the ER door. Yeah. That's great.
Yeah. If you have a horrible trauma, do the debriefings, or go to counseling, whatever you need, take time off, whatever the case may be, but you got to ultimately take care of your mental health in order to continue to do what you do.
That's a good point. It's a really good point.
So some things to forget. I've been racking my brain trying to come up with some of these.
He got the harder. You got the harder question. That's okay. You can phone a friend.
Forget the books, and I don't mean like looking stuff up. I mean like in nursing school, they're going to teach you what it's like an ivory tower hospital. Everything works the same, and etomidate is 0.1 mg per kg, Tom. So, whatever the case may be. But I mean, in nursing school, they're teaching you how everything should work. And then when you get to the ER, you go, none of that shit works like they said that it was going to. So, I don't want to say like, don't forget all your training, but you'll pick up so much with preceptors and with spending time on the floor, learning those things that will stick in your memory forever.
Absolutely.
Secondly, would be forget the losses, but not the lessons learned from it.
That's good. I like that.
You're going to have patients where it just sucks, and you're going to, and I say this because, I'm giving this advice to people who I can't take my own advice, because I can still tell you multiple patients that I'd lost, but you can't dwell on it. Kind of like Tom had said earlier about stuff, but those are sometimes the ones you're going to learn the most from. So you've got to remember, and maybe that's why it doesn't become a sad event in your brain anymore, or an event that, triggers that in you, but instead that really sucked, but I learned that etomidate's 0.3 mg per kg, or I learned what a AAA looks like, or whatever the case may be. You need to remember the learning aspects of it, but try to forget the loss.
Yeah, I like that. I like that a lot. That's great advice.
I don't have a third one. Tom, go ahead.
Well, they're kind of wrapped up in that. And the first one was forget your ego. The minute you walk around like and I mean that throughout your career, because that could get you into trouble later. And you can be a hot shot.
That can be the dangerous patient, right? Or dangerous provider.
You could be a hot shot, super awesome ER nurse, but that makes you really special in the ER. Okay. So you go walking around, go walk up into the ICU and see how well that goes. Okay. The point is at the end of the day, you're there to be part of the healthcare team. You're there to take care of patients. All right. And I think I've actually heard Kevin say this specifically. It's not about you. It's about taking care of the patient. And I think that's one of those things we lose track of sometimes all the time. Like we get so caught up in ourselves that, well, now I got to order, and it happens now in family practice. Well, I got to order this test and blah, blah, blah. And then I'm like, well, that's kind of what I'm here for. Like sometimes you got to step back for a second. Okay, dummy. That's kind of what you're being paid to actually do is this.
Yeah. Someone's getting paid to be here and somebody is paying to be here.
Yeah. So that's
maybe.
And I guess that kind of goes along with don't always think you're special. Now you are special. You're an ER nurse. You are. And if you're an ICU and if you're in med surg, I think if you're a nurse, period, you're special and you're great in your field. Like I would never walk into labor and delivery. Not a chance in hell am I going to be an L&D nurse. Okay. So to me, that's amazing. Like, wow, I'm so glad, and I would never have an L&D nurse come in and work, an amputation and post code MVA. Like, nope, don't want her in here doing this. So you are special within your little world, but this is a big world. Okay. Stop. Don't lose sight of what we're actually here to do. And another thing is when you think you're special, I feel like people that think they're special, like they think they're better. I'm here to have a good time. I actually want to enjoy my day, which is also really hard for people that work with me to understand, but I really do want to have a good time. And I think if you walk around being a jerk all the time or thinking that you were more important than other people, like we all know we all worked with an ER physician at some point that thought they were. And it was not always a fun time to work with that said person because everything was about them. And I'm like, look, bro, like we all got to work here together. I think,
physicians, nurses,
and I don't want this to sound like I'm picking on physicians. I'm not, because it could. Oh, trust me. Some CT texts before I've been like, well, we can't. I'm like, look, bro, put them on the table and hit a button. I don't know what it is exactly what you do, but do it. Okay. Of course, at the same time, that's me thinking I'm special, so I'm kind of breaking my rules. But at the end of the day, that's what it is, though. Is we're all here to work together. We're all here to get the job done, and I can't do what some of the other people can do. And they sure as hell can't do what we do. So that would be the last thing I would tell people.
That's a good point. We all have specialties for a reason, right?
Yeah, exactly.
I think we all have specialties for a reason, and people do what they do for whatever that reason is. And once you find your thing, man, like celebrate. That's super cool.
That's my thing. Yeah.
Lock in on that and go be, the best.
Correct.
Insurance follow-up champion nurse who you want to be, like whatever floats your boat. Like you want to be the wound ostomy nurse of the year, go be the wound ostomy nurse of the year. So.
But you gotta, but there's a reason we have wound ostomy nurses. So somebody's got to be the best. It sure is, it ain't gonna be me. But at the same time, like I said, at the end of the day, there are certain things people would call me and be like, well, what about this, this, and this? And I would have the answer, especially like when I was in trauma. Well, what are we supposed to do about this, this, and this, or blah, blah, blah. And I'm like, here's what the green book says. That's the rule book we played at that time. This, this. It's very clear. But if you'd come to me and said, hey, Tom, we got this tube feeding issue. I'm like, what? You talking to the wrong guy, man. I don't know how to do about that. So
like, let's call an adult. Like, I don't know.
I don't know how many times I've said, I am not. No,
not that nurse.
I am not that guy. Yeah.
You're like, we're gonna need a nursier nurse than me to figure this out.
I need some supervision for sure. Yeah. It's amazing because, like I said just a few minutes ago, we could have been pushing a Tomidate. I felt perfectly fine, but boy, if you're like, this guy, he needs like continuous bladder irrigation. I'm like, what? You better go somewhere else, man. I don't. And I know I speak for every ER nurse just about when I say this. If you hear the words, how many weeks pregnant are they? I'm like, you better tell them to close their legs and hit the elevator on the way through. Cause I don't know what else.
Upstairs.
Yeah, exactly. You ain't stopping here. I don't know what.
I don't know nothing about birthing no babies.
Yeah. If I see anything crying and drop on the floor, I'm not going to be happy. Like, I don't know how many times, like we're here for the other stuff. I'm not here for that part.
Then, Tom, where can folks find you? Where can they find your podcast? And tell them a little bit about your podcast, what you guys do, your podcasts, and tell us a little bit about what your podcasts are and where they can find you.
Well, so we are basically Just Some Podcast Media, and so we started a podcast called Just Some Podcasts for Advanced Practitioners a couple of years ago, and it was initially meant to be kind of entertaining but educational along the way, and was originally directed at NPs and PAs, but we've grown kind of a large following of just healthcare in general, and then even non-healthcare people listen to the show. And it's not that kind of boring reading a PowerPoint education. It's more of a conversational type podcast like what we did here, so we just try to throw some educational bits along the way. And so, we have that show, and we're on social media for Facebook, Instagram, Twitter. You can find us at Just Some Podcast. Our website's justsomepodcast.com. And wherever you download podcasts, you can probably find that show. Then in the beginning of this year, in 2022, we had done several not murder mysteries. We'd done several medical mystery shows. And there seemed to be this groundswell of, hey, we want more of that. That was really cool. We like that. And so beginning of 2022, we launched We'll Continue to Monitor, which is kind of that creepy murder mystery or just creepy stuff that goes on. And so we kind of give the facts, and then we speculate about whether who done it or what happened or whatever the case may be, depending on the case that we're talking about. And So again, you can still the same website, but the social media stuff is we'll continue to monitor. So yeah,
we that one got so popular. Yeah, that's it right there.
It's I opened up my podcast listening app and it was the first one that popped up. So
we try and do it because we'd heard other shows, and like you said, we started as an educational podcast, and so we did a couple episodes like that for just on podcasts. We just wanted to do something new and interesting, and instead of just saying, "Oh, well, then they found them dead," we said, "Well, they were found dead with this type of slash mark, which is indicative of like them being right-handed or being a blunt instrument or being a heavy weapon." So we try and use our backgrounds in emergency medicine, law enforcement, him being a deputy coroner, stuff like that. That we go, well, here's why, so instead of just being like the other podcasts where we're like, well, they saw Bigfoot and then they just move on. We're like, well, were they on drugs? These are the drugs that can make you have hallucinations, so we kind of try and break down the whole episode, not just, the family, like the Hendrik Heifetz, a whole family got axe murdered. Well, we didn't just talk about that. We talked about, the wounds, how they came to those determinations. So if you're listening to it and you're used to just one thing, we're trying to give you a little more broader view, I guess. So yeah, that's why cool. Why I try and tell people when they're like, what's different? I'm like, not a lot, except I talk more. I don't know. That's about it. But yeah, that's it.
That's cool. Well, we'll put links to both shows in the show notes here, so you guys can find them, and we'll give you guys a shout out on social media. Also, so it was great. I hope we come back sometime and do it again. Yeah, absolutely. Well, and one of the questions for the show is going to be, do you want to hear Ben come back and talk about being a deputy medical investigator? Is that something that would be interesting to you? If it is, leave a comment for the show. I'll post that on social media as well to see what the level of interest is on that, which I know is going to be high. So. Well, cool. Hey, guys, thanks so much. Yeah, no problem, sir. And Ben, there must be another body. Another somewhere. One already. Yep. Yeah, he just texted it in the chat. He just texted it in the chat. More coroner stuff. Gotta go. Yep. It happens. That's awesome. Yeah. No, I when I first got into healthcare, I applied for a job at the local body pickup place. Mm-hmm. And they were the EMS crew that would go and saying EMS crews, they in name they were an EMS crew, but the reality was they were just guys that went and shagged the bodies and got the bodies and brought them back. So yeah, I don't know. That was just one of those things. Even when I was a rookie police officer, I don't know, never bothered me. I was like, I don't know. It's just a person to me. Like, I had some funny stories. I worked with a deputy coroner who he was so scared of being around dead bodies. I was like, and here's the other rub is he is also one of the toughest people I've ever, like if you were in a fight or a shooting situation, I'm telling you right now, this is one of the dudes you want there. But man, as soon as they're dead, he's done. Oh yeah. He was like, I don't know how many times I heard the words, "Hey Tommy, can you check for a wallet?" I'm like, are you kidding me? Like, what is going on? So yeah, one of the stories, I don't think I've ever told the story on the podcast. I've told the story, but I don't think I've told it on the podcast. Is one day I was on my way to work, and I was working in Santa Fe, which is a community about an hour from Albuquerque where I lived. And we typically carpooled. I carpooled with the group I worked with, and I was going over to get some coffee, get a cup of coffee before we drove up. So I went to a gas station right around the corner from my house. And I see this guy like laying in the alleyway, and I'm like, oh, he's intoxicated. He's a ETOHer. Like, I honked and said, hey, get out of here, go get a room or something. Get moving. And then drove on by and didn't think much of it. And I went in, got my coffee, got my little breakfast, whatever I was doing, and then I come back out and I see these two girls getting ready to go poke this guy with a stick. Right? Like they're getting ready to go poke this guy. And I'm like going, that's a bad sign. That's a bad sign. I was like, hey, so I get out of the car. I'm like, hey, don't do that. Let me go up there. So I go up there and I see the guy, and the guy's like, the best way I can describe it is he was almost in the fetal position, but face down, like face down, butt up in the fetal position. Like you're sitting there going, okay, if you fell asleep like this, you must have been really intoxicated. Yeah. I don't think he fell asleep like that. Well, and I go, I'm like, hey man, I'm like tapping him with my foot going, hey man, come on, you got to get up, And I lift up his back, the back of his shirt, because that was the part that was closest to me. And I put my hand on his back, and he was just cold. And I kind of, touched his skin a little bit. And I'm like, oh, he's cold and stiff. I'm like, this guy's fucking dead. So I roll him over, and sure enough, he's just deader than shit. He's got a cord wrapped around his neck. And I'm like going, oh my gosh. These two girls that were there, they're running down the street. I'm like going, I don't know where they went. So I called the police, and I'd already called the police and told them that there was a down and out. And so now I got to call the police and I go, hey, remember that down and out I told you about? Well, he's really down.
Yeah, he's super out. Down, like all the way.
So EMS shows up, and they're doing their thing, and the police show up, and they're they're starting to go, okay, well, this is apparently a crime scene now. And I'm just kind of standing there by my car, just waiting to be like, okay, can I go? Like, I gotta go to work, right? Like, I gotta get Santa Fe. And EMS, like, oh yeah, you're good. Thanks for calling it in. He's dead. Yeah, he's for sure dead. So, and then the police goes, wait, hold on. Can I get your driver's license and just get some information? I'm like, sure, yeah, okay. And he goes up, just have a seat. I got to ask you some questions. And I was like, oh, okay, yeah, sure. I was like, oh, okay. I'm standing there by my car. He goes, just hang tight a minute. So I was like, okay. So it starts to snow, right? And I'm like, okay, well, I'm going to just hop in my car. So I open the door to my car, and he's like, oh, hey, wait, what are you doing? I was like, well, it's starting to snow. I figured I'd get in the car. He goes, oh, here, come to my car. It's nice and warm. Right? You know where he's going, right? So I was like, come to my car. It's nice and warm. I was like, oh, sure. Yeah. Okay. So we go to the car, and he opens up the back seat, and here I am in the back seat of the police car. He closes the door, and I'm like, well, shit, there's no handles. Yeah. You can't get out. You can't get out. Like, I'm sitting there going, well, I'm in now. Yeah. Right. And I'm sitting there going, like, okay, here I am in the back of a police car. And then my car, be intimidating. I see my carpool pull up. My carpool pulls up, and I go, hey guys, you guys can go ahead and go without me, because I'm kind of tied up. And they're like, well, where are you? I go, go to the corner, walk to the corner. And they walk to the corner. There's three of them. They walk to the corner, and I was like, you see that police car right there? And I go, yeah. I go, watch it real close. And I was all waving, and they're like, what are you doing in the back of a police car? I'm like, it's kind of a long story, but I found a dead body. And I'm like, so just go to Santa Fe. I'll deal with this now. I'll fill you guys all in when I get up there. So sure enough, they go up there, they go up to Santa Fe, and they're like, well, tell the boss, well, Kevin's going to run a little late because he found a dead body. So the police officer comes to me, and he goes, so, he gets my name, and he goes, tell me the story again. So I tell him the story that, what I know. And he goes, well, you seem real calm for somebody who just found a dead body. And I'm like, well, it's not my first dead body. And he goes, I go, wait, let me clarify. I go, hold on. Yeah. Wait, hold on. That didn't sound right. I go, but I'm an emergency nurse. Like, I've been an emergency nurse for a long time. Like, this isn't my first dead body. Like, I've seen lots of dead bodies. And he's like, oh, okay, that makes a little bit more sense. Like, he goes, because you're just kind of like a pathological liar and just killed this dude. Yeah. Sure enough, this guy's dead. And he's like, do you have a card or anything? And I'm like, no, we don't get cards as nurses, right? I did have cards. I didn't have them with me, but I go, well, I don't really have a card. But I was like, here's who I am. Here's here's where I'm a nurse. Blah blah blah. And he's like, okay. He goes, well, I get your information down if we have any questions. The investigator will call you. And I was like, that's fine. The investigator's more than welcome to call me or whatever. My story's not going to change. I didn't kill this guy. But I just remember him being like, you seem pretty nonchalant for a guy who just found a dead body. And I'm like, all right. Yeah, it's no big deal. Guys, it's been a lot of fun. Thank you for taking the time to do this with me. I really appreciate this. This has been a blast. We can sit here and nerd out and talk about podcasts all day long.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.